Arterial blood gas interpretation. An arterial blood gas, ABG test, is a blood test that requires a sample from an artery in your body to measure the levels of oxygen and carbon dioxide in your blood, also checks pH balance in blood. Sampling, usually drawn by a respiratory therapist, a nurse, or a doctor. Blood is most commonly drawn from the radial artery. Brachial artery, less often femoral artery, can also be used. Blood can be taken from arterial line catheter also. ABG syringes come pre-packaged and contain a small amount of heparin to prevent coagulation. Automated blood gas analyzers are commonly used to analyze blood gas samples. ABG components pH equal sign measured acid-base balance of the blood. PaO2 equal sign measured the partial pressure of oxygen in arterial blood. PaCO 2 equal sign measured the partial pressure of carbon dioxide in arterial blood. HCO 3 equal sign calculated concentration of bicarbonate in arterial blood base. Excess, deficit, equal sign calculated relative excess or deficit of base in arterial blood. SAO 2 equal sign calculated arterial oxygen saturation unless a co-oximetry is obtained, in which case it is measured. Reference ranges pH 7.357, 45 PaCO2, 4.76.0 kPa vertical bar 35.2 45, mmHg PaO2, 1113 kPa vertical bar 82.5 97.5 mmHg HCO3, 2226 mEq base excess, BE, -2 to +2 mol/L. Steps for ABG analysis. Step 1. How is the patient? This will often provide useful clues to help with interpretation of the results. Example: analysis of arterial blood shortly after successful resuscitation would show signs of a respiratory acidosis caused by a period of inadequate ventilation and a metabolic acidosis due to the period of anaerobic respiration during the arrest producing lactic acid. Step 2. Is this patient hypoxic? PaO2 should be in 10 kPa, 75 mmHg, when oxygenating on room air in a healthy patient. If the patient is receiving oxygen therapy, their PaO2 should be approximately 10 kPa less than the percent inspired concentration, FiO2, so a patient on 40% oxygen would be expected to have a PaO2 of approximately 30 kPa/225 mmHg. If PaO2 is on 10 kPa, 75 mmHg, on air, a patient is considered hypoxemic. If PaO2 is an 8 kPa, 60 mmHg, on air, a patient is considered severely hypoxemic and in respiratory failure. Step 3. Is the pH normal, acidotic, or alkalotic? Acidotic, pH on 7. 35, normal, pH 7.357, 45 alkalotic, pH 7, 45. Step 4. What has happened to the PaCO2? Looking at the level of CO2 quickly helps rule in or out the respiratory system as the cause for the derangement in pH. Step 5. What has happened to the bicarbonate? Is the abnormality wholly or partially due to a defect in the metabolic system? Step 6. What has happened to the base excess? A high base excess, plus 2 mol/L, indicates that there is a higher than normal amount of HCO3 in the blood, which may be due to a primary metabolic alkalosis or a compensated respiratory acidosis. A low base excess, 2 mmol/L, indicates that there is a lower than normal amount of HCO3 in the blood, suggesting either a primary metabolic acidosis or a compensated respiratory alkalosis. Compensation respiratory acidosis alkalosis, changes in CO2, can be metabolically compensated by increasing or decreasing the levels of HCO3 in an attempt to move the pH closer to the normal range. Metabolic acidosis alkalosis, changes in HCO3, can be compensated by the respiratory system retaining or blowing off CO2 in an attempt to move the pH closer to the normal range. Anion gap. The anion gap, Ag, is a derived variable primarily used for the evaluation of metabolic acidosis to determine the presence of unmeasured anions. The anion gap is an artificial measure that is calculated by subtracting the total number of anions, chloride and HCO3, from the total number of cations, N+. The normal anion gap varies with different assays, but is typically between 4 to 12 mmol/L. High anion gap metabolic acidosis typically relate to increased production/ingestion or reduced excretion of H+ by the kidneys. Causes of a normal anion gap metabolic acidosis, typically due to loss of bicarbonate, which is subsequently replaced by chloride in the plasma, resulting in a stable overall anion concentration. Let's practice Case 1. A 17-year-old patient presents to A&E complaining of a tight feeling in their chest, shortness of breath, and some tingling in their fingers and around their mouth. They have no significant past medical history and are not on any regular medication. An ABG is performed on the patient, who is not currently receiving any oxygen therapy. An ABG is performed and reveals the following: PaO2, 14, 11, 13 kPa, vertical bar, 105 mmHg, 82.5, 97.5 mmHg, pH, 7.49, 7.35, 7.45, PaCO2, 3.6, 4.76.0 kPa. Vertical bar, 27 mmHg, 35.2, 45 mmHg, HCO3, 24, 22, 26 mcl. Interpretation. How is the patient? Patient is having shortness of breath, may be hyperventilating, may have respiratory alkalosis. Is this patient hypoxic? The patient is not hypoxic. Is the pH normal, acidotic, or alkalotic? The patient is alkalotic. What has happened to the PaCO2? The CO2 is low, which would be in keeping with an alkalosis, so we now know the respiratory system is definitely contributing to the alkalosis. What has happened to the bicarbonate? HCO3 is normal compensation. No evidence of metabolic compensation of the respiratory alkalosis interpretation. Respiratory alkalosis. Case 2. A 16-year-old female presents to hospital with drowsiness and dehydration. They have no previous past medical history and are on no regular medication. An ABG is performed on room air reveals the following: PaO2, 14, 11, 13 kPa, vertical bar, 105 mmHg, 82.5, 97.5 mmHg, pH, 7.33, 7.35, 7.45, PaCO, 2, 3.0, 4.76.0 kPa, vertical bar, 22.5 mmHg, 35.2, 45 mmHg, HCO3, 17, 22, 26 mcl. Interpretation. How is the patient? Patient having dehydration, may be in metabolic acidosis. Is this patient hypoxic? The patient is not hypoxic. Is the pH normal, acidotic, or alkalotic? The patient is acidotic. What has happened to the PaCO2? The CO2 is low, the respiratory system is not contributing to the acidosis, and this is, therefore, a metabolic acidosis. What has happened to the bicarbonate? HCO3 is low, which is in keeping with a metabolic acidosis. Compensation? There is evidence of respiratory compensation as the CO2 has been lowered in an attempt to normalize the pH. Interpretation: metabolic acidosis with respiratory compensation. Thank you. For more nursing-related videos, please subscribe, like, and press bell icon.